We'll move ahead to the next talk and maybe question answers later. If you have to leave, that's okay. Thank you so much for being there.
No,
So
I really
next,
appreciate that. I'm still in my scrubs. I'll run right now, but if I had a time, I would definitely hop
okay,
back again online. Thank you
okay,
so
great,
much. Thank you
thank
so
you.
much.
So next, I think Dr. Cheem has been sitting there for a while. Dr. Shaiban, if you don't mind, I'll ask him to give the talk. His talk is going to be management of cardiogenic shock in acute MI. I think this is a very important topic, and I requested him, and
No
I'm
problem.
grateful that he agreed to
No problem.
do this talk. So, Dr. Cheem, go ahead, please.
Thank you very much, Dr. Bashir Hanif. I hope you can see me. This is the first time I'm participating in your esteemed meeting, and just glad to be here. So this is a topic that I've been assigned, management of cardiogenic shock in acute myocardial infarction. I think before we go further, let's just understand what is cardiogenic shock, the concept. It was first described by Steric Jama 1912, that's quite a long time ago, and it was defined at that time as a sustained systolic blood pressure of less than 90 millimeter mercury for at least 30 minutes or need for vasopressors or IBP to maintain the systolic blood pressure of more than 90 millimeter. You need to have a reduced cardiac index with ensured adequate increased left ventricular filling pressure, and there's got to be evidence of tissue hypoperfusion, whether it's a cool moderate extremities or ligurial or clouded mental status. But we know that the definition of cardiogenic shock has now been taken to a new level, particularly from that of SCI as well as the Heart Failure Society of America, where we now have a consensus statement on the classification of the different stages of cardiogenic shock. The classic cardiogenic shock that we all know of is class C, which is stage C, where the patient has got hypotension, tachycardia, and then supported by dinotropic support and mechanical circulatory support. Of course, now we want to go towards A and B and identifying patients at risk, and of course, E will be the extremes of cases. Now, what are the causes of cardiogenic shock in a patient with acute myocardial infarction? We know that majority of which is because of a large left ventricular myocardial mass damage. But certainly some of the mechanical complications in acute myocardial infarction can contribute to cardiogenic shock, such as ventricular septal defect, acute severe mitral regurgitation, and so forth. And when you look at the mortality by the shock category, looking at the different etiology, when you look at left ventricular failure, the etiology as a etiology for shock, mortality is about 60%. But if you look at some of the mechanical complications, particularly that of a ventricular septal rupture, we can look at a mortality rate of up to 87%. So mechanical complication is not a good thing. So what is the pathophysiology in patients with cardiogenic shock complicating acute myocardial infarction? I think the basic problem here is that you have a coronary occlusion, and then this lead on to ischemia, which affects the contractility of the myocardium, leading to hypertension, lower coronary flow, and then basically perpetuate the ischemic process. Then the coronary occlusion lead on to LV dysfunction, which then stimulate the sympathetic tone and the renal angiotensin system, which lead on to vasoconstriction and sodium and water retention, and that contributes to LV dysfunction. So the way to intervene and break this vicious cycle in patients with cardiogenic shock is really to try to consider a revascularization, which is the basis of the whole treatment here. And second of which is to actually support the heart and improve the coronary flow. And thirdly, perhaps using inotroches to improve the left ventricular function. So I want to take the audience to 4 steps in terms of the treatment algorithm for patients with acute myocardial infarction, beginning with reperfusion therapy, then followed by mechanical circulatory support, then hemodynamics monitoring, and a system approach to that of patients with cardiogenic shock. Reperfusion therapy is still the key because if you look at the randomized trial of all the therapies in patients with cardiogenic shocks complicating AMI, the only treatment that has really reduced mortality is actually revascularization. And we know from a very early period of time, in the 1900s, in the early 20th century, 1999 to 2000, from the shock trial, we realized that in patients while treated with revascularization compared to medical therapy, although in the beginning there was actually no difference in mortality, but for people who survived the cardiogenic shock treated with revascularization, they have a much better prognosis compared to the patients treated medically. Then we have the latest trial called the culprit shock, which taught us that all-cause mortality and renal replacement therapy at 30 days were worse off if we treat patients with multivessel disease complicating AMI, including the non-culprit lesions. So the teaching here is that in patients with cardiogenic shock in AMI, you only treat the culprit lesions, but bear in mind that this is a trial that was done in a setting of no mechanical circulatory support, which is a little bit different from what is being done in current times. So in culprit shock, there was increased risk of death and need for renal replacement with the immediate non-culprit PCR. And so the general recommendation is to delay the complete revascularization to a later stage. But the second most important part of treatment of patient with cardiogenic shock is the mechanical circulatory support. And we know that there are currently many mechanical circulatory support devices available in the market, IBP, impeller, tendon hub, as well as VA ECMO. Tendon hub is not so practical and not available in this part of the world, perhaps because of the learning curve and is not easily used in an acute setting. So IBP, impeller, and ECMO probably form the mainstay of most of the mechanical circulatory support devices used here. Now, when we look at all the different devices, IBP is the worst off in terms of improving the cardiac output, perhaps more than just 1 liter. But when you look at impeller CP, you can improve the cardiac output up to 3.5 liters. When you look at VA ECMO, you can increase the cardiac output to even up to 7 liters here. So different devices does offer you a different level of cardiac output. So when we look at the clinical trials using IBP, both in shock 1 as well as shock 2, and what is clear to us is that IBP does not work in patients who are into a cardiogenic shock. But that does not mean that IBP should be thrown out the window, because I do think that in patients pre-shock, perhaps in stage A or B, there might be still a role. But certainly from these 2 trials, there was no benefit of IBP in terms of mortality compared to no IBP. What is really hot nowadays is the use of the impeller CP catheter, which is also available in this part of the world. This is really a catheter base where you actually pass on a percutaneous mechanical circulatory support all the way into the LV, and then you actively actually suck out the blood from the LV and pump it to the circulations. So between IBP and impeller, one is a passive afterload reductor, impeller is an active afterload reductor. And we know from the various study, again, from the hemodynamic perspective, impeller does improve the mean arterial pressure, cardiac output, cardiac power output, and a reduction in pulmonary capillary wedge pressure. But let's look at some of the early trials use of impeller, particularly from that of Detroit Cardiogenic Shock Initiative. And it actually shows that patients do survive very well if they were treated with impeller. And this very small series of early study of 41 patients with cardiogenic shock, 75% survived to discharge, and there was 100% native heart recovery. But when you look at the ISA shock, which is the first randomized trial comparing impeller versus IBP, we saw an improvement in terms of the hemodynamic, but there was no difference in the 30-day mortality. And therein lies the problem of impeller, that we don't have a randomized controlled trial to tell us once and for all that impeller is really the way to go compared to IBP in patients with cardiogenic shock. The third aspect in terms of treatment of patients with cardiogenic shock is the hemodynamic monitoring. And this we know. By using pulmonary artery catheter and monitoring the patients closely in the coronary care unit, there has been an improvement in terms of the outcomes in people who were treated with hemodynamic monitoring in terms of survival. And two other important parameters that we often measure in patients with cardiogenic shock is the cardiac power output as well as the lactate level. Certainly, by looking at these 2 parameters, you can sort of predict the prognosis of the patients as far as survival goes at 12 to 24 hours after intervention. The last part of which I want to emphasize is really a system approach. Not every primary PCI center is capable of handling a cardiogenic shock patient. What you need here is really to set up cardiogenic shock center within your regional healthcare system and within your region and your country. So assuming if a patient go to a PCI center and that this center is not capable of doing a cardiogenic shock, the recommendation is to call and connect with a cardiogenic shock center, send the team over, put in an ECMO, bring the patients back again to the cardiogenic shock center for further definitive therapy. And this is what we do in NUH here. We do have a ECMO team standby every time it's activated. They will just go in a taxi, go to the hospital with their ECMO devices, put in the ECMO, and then come back in the ambulance to our center for further definitive therapy. And if you look at all the recent investigator-led AMI cardiogenic shock studies, and you look at the survival rate, which clearly has increased from the 1970s of just 17% to about 70 to 80%, there has been some very important best practice protocols that perhaps every one of us can learn from. First is to be able to identify cardiogenic shock early and then consider an early mechanical circulatory support. Instead of now door to balloon time, it's now about door to support time. And we want it to be less than 90 minutes, just like the usual door to balloon time. Secondly, we want to use less of inotropes. Instead of adding more and more inotropes, you want to have aggressive down titration. And you also want to identify situations where there is inadequate LV support and escalate your mechanical circulatory support as and when you think necessary. So a combination of devices sometimes may be necessary, IABP plus impeller at the same time, although I do know that it adds to the cost of the treatment. And certainly a systematic use of right heart catheterizations to guide therapy is critical. So my take here is that you need a multidisciplinary team here comprising an interventional cardiologist, a cardiac surgeon, as well as a cardiac intensivist to really manage this highest risk group of patients. So in conclusion, I think cardiogenic shock, as we all know, is a major cause of death in acute myocardial infarction. Early revascularization is still the primary therapeutic goal. The potential benefit of mechanical circulatory support device should be balanced also by the potential risk or complications and high cost, but I would strongly urge the early adoptions of mechanical circulatory support in this group of patients. And finally, what we really need here is more randomized control trial to truly assess the efficacy and safety of MCS in cardiogenic shock patients. Thank you very much for your attention. I'd like to welcome all of you to Singapore for the AICT Asia PCR in September 2023.
Thank you very much, Dr. Cheem. It was a great, excellent overview. Just quick comments or questions from the panelists or from the audience, if there is any.
I just have a quick comment. I'm a strong believer and a proponent of FFR, but I think we need to ask ourselves, in the era of ischemia trial or post-ischemia trial, what is really the role of FFR? What is the point in confirming there is ischemia? Because we have shown that despite having a large area of ischemia, some may argue FAME2 showed there was benefit, but understand that that benefit was predominantly driven by target lesion revascularization and not hard endpoints.
I think Dr. Madhi has left, but maybe Fahim, do you want to answer that?
Yeah, I mean, I think Cheem has a great point. You know, FFR is a surrogate for ischemia, and ischemia in a large trial did not show benefit in general. And so the real value for FFR to me, honestly, is if I have a lesion and I don't need to treat it, it tells me that. You know, the positive predictive value is very poor. Even in FAME2 at 5 years, there was a trend towards reduction in MI, but that's about it. Otherwise, there was no benefit. So I think that we just have to re-evaluate our thinking, you know, regarding ischemia and flow limitation. But I think the value to me in the cath lab is, okay, I've got a patient on the table. We've decided to do something if his symptoms are in the light of his symptoms. And now I have an intermediate lesion. Do I need to do something? That's where the FFR, IFR helps me the most.
Thank you. Dr. Cheem, I had a quick questions. Like, we don't have Impella in Pakistan. The cost is prohibitive. Do you see any role of balloon pump in cardiogenic shock and acute MI, although the trials hasn't been really supporting? So what do you think about that?
No, like I say, when you have a patients who are in the pre-shock stage, stage A and B, I think IBP still has a very important role. But once the patients go into a full-blown cardiogenic shock, low output and so forth, IABP has got very little usage, just simply because it still relies on the LV to unload itself. So it is a passive reductor here. But having said that, I do understand that there is limitations and so forth in the widespread adoption of the later mechanical circulatory support. What I would urge here is that perhaps some coordination of care in terms of setup of few cardiogenic shock center with these capabilities in your region, and instead of everybody developing the same services, concentrate on a few centers and have these services and resources developed to cater to this group of patients.
Thank you very much, Dr. Cheem. It was a great talk, and I really appreciate you staying that long. And if you have to leave after this, you can. We are very grateful that you were here. Okay.
Thank you very much for the
Dr.
opportunity.
Shaban, if you don't mind, we have a case ready. We have to go to the lab, and we'll get back to your talk after that, if that is okay with you. Can I request Dr. Mohammad Sarwar, Major General Zafrul Islam Saab to come up to the stage, and Dr. Akhtar Ali Bandesha as well, please. And I would like to request Dr. Nadeem Hassan Rizvi to come up here to do the live case moderation, please.